Dr. Rasha Salah, and her talk is about PET MRI in oncology case-based approach.
Good afternoon, dear professors and colleagues. It's my pleasure to be here with you today. Today we are hitting a new era in molecular imaging, which is PET MRI. Let's start with my presentation. This is my acknowledgement where I performed the cases. Today we are going to have a brief introduction about PET MRI, and we will introduce the technique, and we will present some cases. First, to know the applications of PET MRI is very wide. We can use it in neuro and head and neck imaging, also in pulmonary imaging, breast, liver, pancreas, colorectal cancer, uterus, and prostate cancer. So it is a very broad spectrum of evaluation in multi-disease can be helpful in evaluating PET MRI. So PET MRI includes two major techniques, which is the state-of-the-art MRI, which is focusing on the target organ we are assessing, or the primary tumor, and also the state-of-the-art PET imaging to assess the metastatic disease, including nodal and distant metastases. So what is the PET imaging? Briefly, we injected the patient with radioactive material, and then we wait for about 60 minutes, and then the patient go to the scan to start the imaging. What is the difference between PET MRI and PET CT? Why we prefer PET MRI compared to PET CT? First, the agreement between both modalities is very high, and it reaches about 95%. However, PET MRI is more superior than PET CT due to lacking the ionizing radiation, and also it is superior to CT comparing the soft tissue contrast, especially in localizing and staging the primary tumor in some organs, for example, the breast, the prostate, and also the colorectal cancer, where fine details are needed for initial local tumor staging. And also PET MRI have some theories that it can detect smaller nodal metastases, and this was presumed that the longer acquisition of the PET MRI, because MRI take longer time compared to CT, so we can detect smaller metastases by allowing more tracer accumulation within these micrometastatic lesions. And so we can properly stage these patients. Also, MRI is superior compared to CT, especially in evaluating bone marrow lesions, where sometimes bone marrow lesions can be masked completely by CT. Let's start with the preparation, what we do for our patients. First, we ask the patient to be fasting for about 2 to 6 hours, and also we need to adjust the blood glucose for the patient if the patient is diabetic, and we all perform the same preparation protocol as the CT, including some rest the day before the examination, no vigorous exercise, or some medications can be controlled. Also, kidney functions is needed because we can inject IV contrast in the MRI study. Sometimes we need anesthesia, and for the longer acquisition time, the patient should evacuate the bladder immediately before the exam. Our PET MRI protocol includes whole body evaluation for the lung, the lymph nodes, bone, and to evaluate the rest of the organs. Also, a dedicated local evaluation for the primary tumor, which is the target organ, and we perform the dedicated MRI study for this organ. Let's see some of our organs. First, we will assess the lung. As of course we know, CT is superior compared to MRI in evaluating pulmonary nodules. So we can have some limitations in evaluation of pulmonary nodules, especially when we are performing PET MRI. But let's see these cases. This is a patient with these two pulmonary nodules on the CT, and they are showing avid uptake on the complementary PET CT images. And on the conventional MRI, which is just a T2 MRI, not a PET MRI, we can nicely see these nodules over here without using a dedicated technique for evaluating these pulmonary nodules. So if we are needing to evaluate pulmonary nodules, we can do this task by MRI, even with the conventional sequences. And also smaller nodules can show more activity in PET MRI, again due to longer acquisition time, as we can see over here. But MRI is very helpful recently due to dedicated techniques for evaluation of pulmonary nodules, which is known as ZTE imaging. Let's see this example, this patient having this small pulmonary nodule on the CT, and this is the complementary ZTE MRI technique. We can see the same nodule exactly nearly the same as we can see on this CT. And another example, we can see this small nodule on the CT, and also we can see this nodule on this magnificent technique, which is the ZTE MRI. This is from our patients. This was having this sizable nodule at the fissure, and this is the CT image, and this is the MRI, and this is the fused PET image. In spite that the lesion is almost negative on the PET image, but we can nicely see this nodule on the ZTE MRI. Even we can see the vasculature as the CT images. So this is very helpful in evaluating pulmonary nodules. Let's move to another use of the PET MRI regarding breast imaging. I just want to highlight that PET imaging in evaluating lobular carcinoma sometimes having negative results, because lobular carcinoma apparently are negative on the PET imaging. So we need to combine the PET CT and the local MRI for evaluating of lobular carcinoma, especially because of its multicentric affection. Also, recurrent lesions is a very diagnostic dilemma in breast cancer. And let's see this patient. This was a 51-year-old patient having breast cancer, underwent previous conservative surgery and axillary clearance, and presented with pain at the operative bed. Serial sonomammographic studies show that this was just a scar and attribute some inflammatory changes around this scar. The patient came for PET MRI. Let's see her MRI image. In the PET MRI, we perform the complete breast MRI technique with all its sequences, including dynamic and diffusion, and then we perform the complementary PET images. This is the T2 showing nodular lesion along the line of the scar. And this was the dynamic study showing heterogeneous enhancement of this nodule with early enhancement and the time intensity curve of type 3 curve. So as far as these images alone, this is worrisome for recurrence along the scar line. Also, when we performed the perfusion image, the lesion is hyperperfused, and this is controversial to a normal scar, because normal scar should be hypoperfused, not hyperperfused like this nodule. So as far as MRI, this is very suspicious for recurrent imaging, for a recurrent breast lesion at the operative bed. When we combine this MRI to the applied PET imaging, we show that there is a concordant results with minimal uptake along this nodule in particular, and the rest of the scar show no apparent uptake all over its course. So the MRI and PET image confirm the recurrence, and it was pathologically proven to be small recurrent nodule along the scar. Let's move to the liver, particularly for HCC, where the PET-CT alone has a diagnostic dilemma because it appeared to be negative in well-differentiated HCC, and also in post-treatment lesions, especially if local regional treatment were applied. However, due to the higher resolution of MRI, we can differentiate between post-treatment changes and also the recurrent tumor. This patient have previous radioembolization and came for evaluation. So we can evaluate that there is avid uptake at the periphery of the radioembolized focal lesion, and also corresponding significant restricted diffusion, and these combined data confirm that there is a sizable residual viable tumor at this left lobe lesion. And this was his map imaging showing some other lesions over here and suspected minimal uptake over here. Let's see the other treated lesion, which was completely negative on the PET, and this confirmed that this was a well-treated lesion. Another smaller lesion that was very nicely seen on the PET and also on the diffusion weighted image. So we can localize that there are multicentric bilobar affection, not only the target lesion at the left lobe. Also, there is tumoral thrombosis at the left portal vein, and this can be nicely seen on the fused PET images and also on the conventional T2 weighted image. And again, the pulmonary nodules, which show increased uptake over here, with also metastatic mediastinal lymph node. So it is very helpful in evaluating the primary target organ, which is the liver, and also evaluating the metastatic load. Let's see its role in pancreas. This was metastatic pancreatic mucinous cystic adenocarcinoma, and as we know, mucinous cystic tumors are showing low FDG uptake. So if we perform just a CT, we can miss the primary lesion and also the metastatic load. As we can see here, this is the fused PET MRI. As we can see, no uptake was noted either at the pancreatic tumor or even elsewhere in the abdomen. And the MRI showed that there is a mixed solid and cystic tumor at the pancreatic tail over here. And there were also multiple metastatic peritoneal deposits which appear to be nearly negative on the PET, but they are very nicely demonstrated on the diffusion weighted image, as we can see here. And also the minor perihepatic peritoneal deposits, which can be very easily demonstrated on the diffusion, in spite that they are completely negative on the PET images. And also regarding the lymph nodes, this is a huge lymph node which is completely negative, but it is very easily visualized on the diffusion weighted image. And also the left supraclavicular lymph node, which is very easily seen on the MRI and completely negative on the PET. Regarding the osseous metastasis of this lesion, it was also completely negative on the PET image, but we can see that there is widespread osseous metastasis, marrow infiltrative lesions, demonstrated on the T1 weighted image and also on the MRI. This was the CT of the patient performed just a few days before the PET MRI, and it was completely negative for osseous metastasis. And this is a comparison between his PET CT and PET MRI, because both are negative for any avid lesions, in spite the patient is having heavy metastatic load. So we can discriminate the CT and the MRI to evaluate the mucinous tumor, because we can visualize the metastatic load nicely on the MRI, and it was completely negative on the PET images. Let's start with the rectum. It has a very important role in evaluation of initial staging, restaging, and also in recurrence. In initial staging, we need the proper local staging of rectal tumors, including mesorectal involvement and extramural vascular invasion, and this task is performed by MRI very nicely. As we can see here, that not only the tumor is avid, but the extramural vascular component is also avid as well. We can evaluate the mesorectal fascial involvement, peritoneal infiltration, and also the small nodal metastasis, as we can see here. Also, tiny metastatic abdominal lymph nodes can be nicely visualized on the PET MRI. As for distant metastases, in spite of the negative uptake on the PET imaging, they can be also visualized on the MRI depending on diffusion and T2 weighted images. And another example for negative PET imaging for metastatic focal lesions, but they are nicely demonstrated on the MRI component. Also for peritoneal involvement, it is very easily demonstrated on the MRI compared to the PET. In recurrent rectal tumors, it is very difficult to discriminate between post-surgical changes and recurrence, and MRI is very helpful in evaluation of this task, because in the recurrence there is diffuse uptake at the operative bed, and this makes the discrimination depending on the PET alone somewhat difficult. But here on the MRI we can see that on the diffusion weighted image there is a true high cellular packing, demonstrating that this is a true recurrence, not just inflammatory changes as opposed to surgical changes. In the prostate, it has a very important role. Let's start with the staging. For the primary tumor, by the MRI component, we can evaluate extra capsular involvement, seminal vesicle infiltration, which is important for local staging of prostate tumor. And also for the nodal evaluation, in spite of these are small lymph nodes and they are non-specific on the cross-sectional imaging, but they are showing significant uptake on the PSMA PET study, and this indicates that these are true metastatic lymph nodes. And also these small common iliac lymph node, which is could be neglected and missed on the conventional images, but it is very avid on the PET component, and example for tiny left para-aortic lymph node, which could be missed on the conventional image, that help in proper staging of this patient. Also, these patients have a tiny left supraclavicular lymph node, making this patient to be upstaged into M1A due to left supraclavicular nodal metastasis. Let's move to this nice case with the patient known to have a prostate cancer coming for staging for local and distant evaluation. This is the infiltrative prostatic tumor located at the peripheral zone, and its complementary significant increased PET uptake. And this is the extracapsular component with nearly infiltrating, completely infiltrating the right neurovascular bundle, infiltration of the seminal vesicles, and also the nodal metastasis. All these are concordant with the patient with also small common iliac lymph node. But the other questionable lesion that was located at the left distal ureter, located over here, we can see that this is another lesion, and we suggested that this was a second primary, which is a TCC in the distal ureter, and if the patient was performed PET-CT, it could be masked with the normal tracer accumulation within the ureter. And finally, the diagnosis was not only for evaluating the prostate tumor, but also we diagnosed another second primary, which is a TCC at the left distal ureter, and it was pathologically confirmed. For treatment response, this is an example for a patient underwent previous HIFU, which is a high-frequency ultrasound treatment for the prostate. We can see that there is a cystic change at the left peripheral zone with completely negative restricted diffusion and no perfusion, and this indicates that this is a well-treated lesion. But the patient has a high PSA level. So we performed the PET MRI for evaluation, and we can notice that this is a small left pelvic lymph node, and it is equivocal on the cross-sectional imaging. However, it shows significant PSMA uptake, and this was proved to be metastatic nodal disease. Another larger left pelvic lymph node was also demonstrated, and the patient was treated primary tumor. However, there are a few metastatic regional lymph nodes. In biochemical recurrence, it is very important to evaluate the location and the load of the biochemical recurrence. This is an example for how MRI perform in biochemical recurrence. This is heterogeneous appearance around the bladder neck, which is the most common site for biochemical recurrence. And on the diffusion weighted image, this is showing restricted diffusion, and such restricted diffusion is demonstrating that we can say that this is not a fibrosis at the operative bed, but this is a true recurrence. And this is the hyperperfusion located at the perfusion study, and this was concordant with the PET imaging that it shows significant uptake. However, if we missed this MRI component, we can presume that this is a funneling of the bladder neck with the accumulation of the tracer at the bladder neck over here. But because we have the solid data from the MRI, we can confidently call that this is a true operative bed small recurrence. As for the uterine cancer, it is very important for local staging, for evaluating the myometrial involvement, and this task is exclusively performed by the MRI component, not only by the PET component. And we can see here that this tumor is infiltrating the myometrium more than 50%, and this was confirmed also and concordant to the complementary PET imaging. So to sum up, PET MRI avoids radiation exposure, and it allows state-of-the-art local proper staging, and also it has an additive role in evaluating nodal disease and distant metastasis, especially if we suspect marrow involvement. PET MRI potential role in treatment response evaluation, and also it can discriminate between post-surgical scarring and fibrosis from true recurrence. Thank you.